Hello and welcome to another episode of Psychotherapy Networker Live. I'm Chris Lyford and I'm the senior editor here at Psychotherapy Networker magazine. Thank you so much for joining us for a very special discussion with Sacha McBain. Sacha, thank you so much for joining us.
Thanks for having me.
So Sacha is a clinical psychologist and assistant professor at the University of Arkansas for Medical Sciences, or UAMS. She serves as the associate director of the Center for Trauma Prevention, Recovery, and Innovation at UAMS and leads implementation of screening and brief intervention efforts on UAMS's trauma surgery service to address the mental health needs of patients who've experienced serious injury or illness. She also provides training and consultation to medical services on how to implement trauma-informed and trauma-focused care practices. Sacha is also the author of the in-consultation piece in our September issue titled Recognizing Medical Trauma, How Therapists Can Intervene. I also want to let everyone out there watching know that we're offering a special discount on Psychotherapy Networker magazine. For a limited time, you can get a year-long subscription for just $12. We'll post a link along with this video wherever you're watching. So just follow that link to get your discount subscription. And we'll also be posting a link to a seminar that Sacha has. If you're interested in checking that out, click that link as well. But today we'll be discussing the subject of medical trauma. What is it and what do therapists need to know to treat it? So, Sacha, let's just jump right in. What is medical trauma and what distinguishes it from other types of trauma?
Yeah, so medical trauma is like, when we think about the definition of trauma more broadly, but focus on medical events. And so what that looks like is a set of psychological and physiological responses to what we know can be really stressful types of medical events, things like pain, injury, serious illness, like life-threatening or life-altering diagnoses, different procedures, or just frightening treatment experiences. And so medical trauma is unique in that the threat comes within the body. So if we think about like something like a car accident, we can kind of know when it starts and when it ends, and that can be contained into one narrative. Whereas if we think about something like medical trauma, it's happening from within the body. So for example, a heart attack. And so that threat can be ongoing and it doesn't necessarily end after that first heart attack. Like that threat continues to be experienced within the body. And so it can be this continual or long-term or even permanent exposure to the threat that is an intrapersonal experience, something that's happening within the person and within their body, but also an interpersonal experience, how they're interacting with things like the healthcare system or other areas of their life.
Mm-hmm. So how did you learn about medical trauma? And as you learn more about it, what surprised you?
Yeah, so I first started really thinking about medical trauma when I was an undergraduate at a cancer institute I was working at as a research assistant there. And so my job was to do qualitative interviews with patients and families who are navigating colorectal cancer. And so as I was doing those interviews, I really just heard a lot about how traumatic and destabilizing diagnosis and treatment and recovery was for patients and their families. And so there wasn't a lot of talk about that. That wasn't really something that was discussed or, highlighted when it came to cancer recovery or cancer survivorship. And so that really got me interested in thinking about what are we doing to help people who are navigating these life-threatening and life-altering diagnoses. And so as I got into the field of early intervention for PTSD, I started to really build my career thinking about how do we better embed trauma-informed and trauma-focused treatment in these medical settings where these traumatic experiences are happening, which is a unique opportunity because we don't always know when and where trauma is going to be happening. But with these types of events, we can have a pretty good idea. As I got more and more into it, the thing that really surprised me was just how little it was recognized or acknowledged within our healthcare system as at large, and the ways in which that trauma is intentionally perpetuated in healthcare and in families and in our society more broadly.
So how should clinicians assess for medical trauma and how should they treat it? Do they need specialized training?
Yeah, so I think when we think about medical trauma is an experience, not a diagnosis. And so I think that first you want to assess if your client has been, in fact, exposed to potentially traumatic events as a whole, and then including potentially traumatic medical events. And so so we need to understand exposure first, and there are tools to screen for that. So something like the life events checklist, for example, which is open source, available on the National Center for PTSD website. There's also more specific measures to look at medical trauma specifically. And there's other tools to kind of think about how are we assessing for health related quality of life impacts. So something like the SF-36 is a good example of measuring different domains where there might be some impact. So once we kind of have established like this stressor happened, it's currently impacting somebody's life, we then want to look at the clinical symptoms associated with that. So then you can think about things like the PTSD checklist. There's lots of measures online. If you Google if you're working with a patient, with a particular diagnosis or treatment experience, you can Google, like cancer mood assessment or things like that, and find different self-report measures to really get a sense of how this is impacting someone. We know that medical trauma, again, PTSD isn't the only potential outcome. So we can also be assessing things like anxiety, depression, whatever it might be, to really get a good sense of what the symptoms are and combining that with a good clinical interview. When it comes to treatment, that is going to be really dependent on the diagnosis and the symptom profile, and of course, the client's goals for treatment. So if we're thinking about, we've done all of these steps, we've kind of come to the conclusion of like, I think, this person has PTSD related to a medical trauma. I've had a lot of success in using, the trauma treatments that we know work for PTSD generally. So things like cognitive processing therapy, prolonged exposure, and EMDR have been really helpful for many of my clients. One of the things that I'm working on now is how do we adapt these treatments to really get at the nuance and the unique aspects of medical trauma that aren't captured within these existing protocols. So things like how do we make sure to thoughtfully integrate in things like pain management, which can also be trauma cues, and how are we managing or helping with resolving pain or tolerating distress around pain that might be triggering of the trauma itself. Things like body image or internalized ableism that often comes after somebody experiences a life altering injury or illness. And I really suggest, I'm going to make a plug for somebody else who I've learned so much from, is this book. It's the only book that I know of on medical traumatic stress. It's by Michelle Flomhall and Scott Hall. Has a lot of great tools for conceptualizing and thinking about the nuance of medical trauma. And we are working hard to get more information out there about how to treat this specifically.
Great. Now, in your networker piece, you call medical trauma a disenfranchised trauma, an experience that's not openly acknowledged or socially validated as traumatic, including by the field of trauma treatment. Can you tell me a little bit more about that?
Yeah, so I think the first thing is that I think there's a push and pull right now when it comes to trauma, as we talk about it more generally. I think that there's been a lot of criticism of like, trauma's everywhere, trauma's everything. And I think that there has been kind of some conflating about what trauma is and what it results in. But at the same time, we are still deeply under-recognizing, under-appreciating the true impacts of trauma and how it shows up in our lives. And so there's this push and pull around like, well, everything's a trauma now, but we're still not acknowledging the things that really are deeply traumatic and can lead to these outcomes. And I think that's very true with medical trauma, because it could happen at any level of care. And it can lead to like all sorts of types of distress. And so I think it's a big ball of different things that are hard to split out. But also because so many people have likely had these uncomfortable or distressing experiences when it comes to their healthcare, their health, the family members' health, whatever it might be. Sometimes when there's that ubiquitous ubiquity can really dilute understanding of the more complex and chronic reactions to medical trauma. And so it keeps people from really knowing about it, talking about it, or seeking help. And these types of traumas are happening within systems and institutions that aren't really designed to promote patient advocacy or autonomy. And so when we think about how do we truly address medical trauma, know where it's coming from, and how to mitigate that, it requires such a massive systemic overhaul that we kind of, as a result, it kind of just becomes like, oh, it is what it is. Like, this is just what cancer treatment is. This is just, the burden that women have to bear after giving birth. Like, this is just part of it. Like, Mother Nature kicking you when you're down is something that we often hear. And that doesn't have to be the case, but it requires so much work and really a cultural overhaul. And so I think that as a result, this type of trauma has become mostly unspoken and therefore disenfranchised.
Well said. You also write in the piece about the importance of promoting language and awareness around medical trauma, and how a lack of both makes it both harder for clients to talk about it and leaves clinicians more prone to diagnosis. I'd love to hear a bit more about that.
Sure. So I think, generally speaking, this is the challenge that trauma-informed care initiatives have tried to take on. Like, how do we as a field better understand our clients, our patients, through a holistic lens and through a shared narrative of their constellation of experiences? And so I think being able to conceptualize our clients through a really culturally humble and expansive lens helps us get closer to really understanding what our clients need. But we also just don't have enough clinicians who are trained in and routinely providing trauma-focused treatment. Like, that's a struggle in our field generally. And then you take this niche topic area where we don't have a lot of specific research, and it makes it easy to miss. And so I think having a foundational understanding of traumatic stress helps fine-tune your ability to assess for how life experiences generally, including medical trauma, might lead to traumatic stress responses, and think about how these symptoms are influencing behaviors, even when they might not be meeting criteria for PTSD, but being able to really think about like the function of behavior and where these things might be coming from, and being grounded in a trauma-informed and trauma-focused practice, I think will naturally lead you there. And if you don't have that, I think being able to kind of seek out some of the more traditional, trauma-focused PTSD treatments will help you to get that skill set to be able to like pick this out and recognize it more within your caseloads. Great.
So what message do you have for all the therapists watching out there who may be working with medical trauma survivors?
Yeah, I would encourage those watching to, the number one thing that I always say in my trainings is like, this isn't a new skill set necessarily. Like, I think that it's important to expand your skill set into areas like health psychology, like rehabilitation psychology, who have really been thinking about the psychosocial impacts of health crises for a long time. But how do we overlay the trauma piece to that? And so I think there is partly getting more skills, getting more knowledge around how to address and treat the things that are important to people who have experienced medical traumas. But really at its core, I think it's really shifting your intentionality around how you assess and think about the impact of past or ongoing medical events on your clients or patients. And so I would guess that many of the people watching this can think of clients who have a long list of health comorbidities, and you're treating the depression, you're treating the PTSD, you're treating whatever it is. And then over here on the side, there's COPD, there's a history of heart attack, there's all these things over here happening. And so I think just first, like moving beyond noting those diagnoses and, asking when their last visit to the doctor was, and really getting curious about how chronic illness, injury, et cetera, is related to their mood or their coping or their sense of self, or how they're navigating their relationships and how it might be influencing their values or goals when it comes to treatment. the last thing that I'll say too is that I also notice when these types of patients or clients are coming into people's offices, their pain points come from this kind of pressure that we have in mental health, to kind of like align with messaging in the healthcare system that overemphasizes a client's internal locus of control. Well, if you ate better, well, if you did this, if well, how do we work on getting you exercising more? Which are important parts of somebody's health, but I think we can be quick to overemphasize that in a way that isn't really in the moment acknowledging what's happening. And so I guess it's like moving away from the immediate fix it mentality and thinking about what is really driving some of this behavior, what's driving this quote unquote non-adherence to treatment, and is this partly a process related to emotional avoidance? Is this some like an unprocessed experience here? And so really thinking about, like, when it comes to health especially, how do we move away from some of the mindsets around like this is 100% this patient's responsibility, and really think about them through an ecological framework of them as an individual, their family, their community, our society as a whole, and how that's impacting their health behaviors and how they are experiencing their own health.
Great, great. Well, Sacha, thank you so much for joining us. You've been so gracious with your time. This has been really helpful, very, very informative. Thank you again.
Thank you so much for having me.
You can read Sacha's in-consultation piece in our September issue. It's called Recognizing Medical Trauma, How Therapists Can Intervene. Another reminder that we're offering a special discount on Psychotherapy Network magazine, just $12 for a full year of issues when you follow the link included with this video. Thank you so much for joining us. Till next time, I'm Chris Lyford. See you again soon.